Hello, my name is Manesh Patel. I'm the Chief of Cardiology at Duke University and direct the Heart Center. And thanks for joining this program on starting and maintaining an anti-thrombotic program in your patients with peripheral vascular disease. If you look at this slide on the mechanisms of anti-thrombotic medications and the clinical consequences of atherothrombosis, it's important to recognize that this central figure highlights for you a lot of the mechanisms and therapies we have. On the left side of the figure, you see the standard activation of a plaque rupturing anticoagulation cascade, where factor Xa inhibitors and other therapies are really critical at inhibiting prothrombin to thrombin. And then thrombin activation of platelets or platelet activation is inhibited by another set of therapies that we've talked a lot about, a lot of evidence in this space around aspirin, vorapaxar, clopidogrel, prasugrel, ticagrelor. These are drugs that inhibit either P2Y12, PAR1, or thromboxane A2. Obviously, when atherothrombosis happens, depending on the vascular bed that's involved, it leads to downstream events such as stroke, MI, lower extremity events such as ischemic limb or revascularization needs. And so picking the antithrombotic therapy, the right dose in the right patient for the right atherosclerotic burden will be critical. This slide here might highlight at least the biggest steps over the last 20 years in our practice, which is we've moved from a platelet-centric approach. Now, I grew up in a world where more antiplatelet therapy was felt to be better because we were putting stents in patients and they had more stent thrombosis. But if you look through these trials, we've learned some key lessons. In chronic coronary artery disease, aspirin compared to clopidogrel, a slightly stronger antiplatelet therapy, was inferior. Clopidogrel, a slightly stronger antiplatelet therapy, was about a relative risk reduction of about 8%, 0.5% absolute risk reduction, and significant, but not very large. Charisma looked at two drugs, clopidogrel and aspirin, DAPT versus aspirin in chronic cardiovascular disease, and showed no significant difference. When we think about chronic CAD and PAD, the dual antiplatelet studies, I told you about Charisma. If I think about the DAPT trial, we know that once you've gone out to a year with stents, prolonging that seems to be beneficial in some patients, but there's a trade-off of bleeding and mortality doesn't seem to go in the right direction. So you have to pick the patients. MI patients getting ticagrelor and aspirin versus aspirin alone in Pegasus got a MACE benefit, but there's a bleeding benefit, a bleeding risk to discuss. So again, having to pick the right patients. In chronic PAD, we studied in Euclid more antiplatelet therapy with ticagrelor compared to clopidogrel, and at the end of several years, no difference in more antiplatelet therapy improving outcomes for heart or limb in chronic PAD. So it's on that background of not clearly seeing a huge benefit with more antiplatelet therapy that we think about the two more recent antithrombotic therapy studies, COMPASS and Voyager PAD. COMPASS identifying for us stopped early for a mortality benefit, patients with rivaroxaban and aspirin in broad atherosclerotic burden patients, CAD, multivessel basis, polyvascular, a lot of risk factors, 2.5 milligrams twice daily rivaroxaban and aspirin compared to aspirin alone did reduce MACE. And then when we think about our patients undergoing lower extremity revascularization, Voyager PAD, and then over 6,000 patients showing that adding 2.5 milligrams of rivaroxaban on top of aspirin compared to aspirin alone, and people could have used clopidogrel, which we'll go into in a second, reduced both limb events and heart events, but really driven by limb events, and an important finding for our patients undergoing lower extremity revascularization. So moving from more antiplatelet therapy to potentially the right dose of dual pathway inhibition. So the key question for any practicing physician is, when should I start a patient on an antithrombotic program? What are my treatment alternatives? Do I need to add more than aspirin? Is it clopidogrel? Is it rivaroxaban? Is it something else? How long do I treat? And what do I do about the medications if my patient has to have another procedure? So these are everyday questions that I think hopefully we'll try to answer in the next few minutes. The first one, when should I start a patient on an antithrombotic program? A simple one for me in our patients with vascular disease is if they have a revascularization, then you know in the lower extremity, those patients are at very high risk. The Voyager PAD data that you just saw showed at 3 years, the event rate for MACE in male in those patients who've had a lower extremity revascularization. Majority were endovascular, but a significant number were surgical. 19% of those patients, 1 in 5, have an event at 3 years. Somewhere around 5 to 6 days after the surgical revascularization, 3 to 4 days after the endovascular revascularization, these patients were started on therapy. So I would say take the moment. I've even started it sooner now in my clinical practice. Somebody has an endovascular revascularization, I would start the therapy the day they're going home, and it can happen certainly within 6 days when they're stable. And I think that therapy significantly supports their limb. Our patients with chronic vascular disease, who should I be thinking about? The more vascular beds that are involved. And when I think about vascular beds in the COMPASS trial, I think about people that have peripheral artery disease, coronary disease, diabetes is a multi-vessel disease, renal function, the renal bed is just another vascular organ. Creatinine is an example of a great renal vascular measure. And then, of course, patients with multi-vessel cardiovascular disease leading to heart failure. Those are high-risk patients that I would be thinking about more than usual antiplatelet therapy. What about treatment alternatives? Are there alternatives to clopidogrel? So again, here in the Voyager trial, patients who were randomized to rivaroxaban on top of aspirin versus aspirin, undergoing a lower extremity revascularization, they were allowed to have clopidogrel. And as you can see on this slide, those with or without clopidogrel, the p-value for interaction is 0.92, so no interaction, meaning no effect of clopidogrel on attenuating or improving the difference in events. Published by the late great Will Hyatt in Circulation 2020, you can see that the absolute risk reduction is over 2% on either way, 2.3 or 2.8. Again, 1 in 50 patients or so, or 1 in 30 patients, you would get a benefit of reducing an event if you did this for them in the next 3 years. So the next 10 to 20 patients you see with endovascular or surgical revascularization, clopidogrel is not changing their outcome. It's likely if you have the ability to add rivaroxaban. And this comes obviously at some bleeding risk. So, if you wanted to use it for 30 days after the procedure, I'm totally comfortable with that. Some of my endovascular colleagues do that. But certainly after that, I think you have to consider dropping clopidogrel and ensuring that the patient stays on rivaroxaban. Now, some have asked me, is this a class effect? Could we use apixaban? I think this is a key feature. Could it be a class effect? It could. I don't know. But you have to get the right dose. And so it's important to recognize 2.5 milligrams of rivaroxaban is nearly 1/10 of the 20 milligram AFib dose, whereas 2.5 milligrams of apixaban is the dose reduction for AFib. The AFib dose is 5 milligrams BID. I don't know what dose of apixaban I would be using in my vascular patient. It certainly would not be 2.5 because the bleeding rates would certainly be much higher than what we saw in this trial. So I would not go off-label in an unstudied agent. Could there be a class effect? Sure, but it's really important to recognize that that therapy has not been studied. And so you should use proven therapies in our patients, especially when you're doing these trade-offs. How long do I continue the treatment? Another really important feature. And what's really interesting and important is to recognize that in most of our patients, when we increase their antithrombotic therapy, they have a bleeding risk, but that bleeding risk is early on. Once that bleeding risk is tolerated, we often see that beyond 6 months, they no longer have a risk of bleeding because if they had an ulcer, if they had other things we've identified, but they continue to get the benefit for thrombotic events. So if you look at this nice figure from Sebastian Debus in Circulation 2021 that we published from Voyager, that the benefit persists for at least 3 years after a revascularization procedure, and the curves are still separating. So I would be thinking at least to think about several years of therapy to protect that patient. And finally, what do I do if my patient requires another procedure? And remember, a lot of our patients have acute limb ischemia, major vascular events in the limb. They have a heart attack. Unfortunately, sometimes they can have a stroke. This analysis by Rupert Bowersox in the Journal of the American College of Cardiology 2021 is really powerful. It looks at total events. And aspirin rivaroxaban dual pathway inhibition reduced not just the first event, but the total events for the patient, recurrent events. Being able to stay on the therapy, reduce the total events. And in fact, the number of events patients recurrently have is pretty substantial. If you look on the right side of that slide, or if you look on the KM curves, you can see that if anything, the total vascular events start to separate even more by 3 years. And the total vascular events leading to 6, 7, 8, 10% difference tells you just how big an event opportunity you have in your patients. So thank you for listening to this conversation about how to manage and how to go through standard therapy for your patients with PAD and CAD and chronic vascular disease. I appreciate your attention, and we hope you've gained something of this. We look forward to having you listen to our future sessions.